nice to be here. Thank you. So thank you for the kind invitation to come and speak to you. The topic of my conversation today is cortical dynamics in the visual areas induced by first-time multifocal contact lens wear. And Mr. Giorgio Righetti asked me to make this presentation based on a recent paper that we published. But before I talk about the exact paper and the results, I just wanted to give you the background to the paper. So first of all, my disclosures. I had some research grants from various companies. So we know that presbyopia is a big problem. We know it's one of the big areas of research. It's a big part of our clinical practice. And it's estimated that in the next 25 years, there'll be nearly 2 billion people who are presbyopic. In fact, it could be more than 3 billion if we include the low myopes who are not wearing any correction when they make their reading, when they read. So let's start with thinking about the presbyopic dilemma. What we know, as you get older, the usage of contact lenses actually decreases. So although presbyopes need contact lenses, in fact, the contact lens usage in presbyopic age groups is reduced. But when we compare this to our ophthalmology surgeon colleagues, they like to use multifocal designs in intraocular lenses. And if you go to any surgical conference, you will hear them talking about extended depth of focus intraocular lenses and how these are very successful. In fact, all of the intraocular lens designs that we have for multifocal are based on contact lens designs. So this graph here is just showing you from 2009 to 2019 in the USA, how many products were available in each of these categories. So you can see, first of all, that for spherical contact lenses, there were 70 products, now there are 80 products. For tinted, there were 13 products, now there are 18. For toric, 39, now there are 53 products. But for multifocals, there were 22 products in 2009, and now there are 43. So this represents, in the multifocal category, an increase of nearly 100%. So there are double the number of designs that there were 10 years before. So this is a really big area of growth. So people talk about how we adapt to multifocal contact lenses. And in fact, multifocal contact lenses use this principle of spherical aberration. But by increasing the spherical aberration, you compromise the modulation transfer function, the MTF. So the best vision you will get is when your MTF is highest, but the spherical aberration is the least. But if you increase the spherical aberration and reduce the MTF, then you actually increase the depth of focus. And by increasing the depth of focus, you can give your patient an increased near ability, reading ability. Now, I'm sure you know when you fit your multifocal contact lenses to your patients, many of your patients adapt very quickly to the contact lens design. There are some patients who don't adapt very well, and you need to change the product. So the way that the brain supports the multifocal contact lenses isn't actually known. Is there a way that we can predict which lens will be more successful for which patient? So just to give you the background of electrophysiology. Electrophysiology is the study of electrical properties of the biological cells and tissues. It doesn't mean that the cells and tissues are creating electricity. This is the impulse in the cells. And it's a calculation or a measurement of that impulse. And there are lots of electrophysiological measurements we can take in the body. And here just highlighted are the ones that we can take in the eye. I'm sure many people have heard of electroretinography, ERG. And you will have heard of EEG, electrosonography as well. You probably also heard of event-related potential. And this is where a stimulus is presented to the eye and there's an increase in the evoked potential. And a visually evoked potential is where the stimulus is a visual stimulus. So you probably heard the term VEP. So remember, the brain does not produce the electricity, and the signal is produced by the neurons and the synapses between the neurons. And there is an excitation phase, and there's an inhibitory phase as well. So there's an inhibition of the signal as well as an excitation of the signal. So you can think of this as a forward signal and a backward signal. And you can measure this in the eye by putting electrodes on the scalp. And of course, we know the eye has the visual pathway and the visual cortex is in the occipital lobe, but we can measure along the pathway as well. So essentially, this would be our stimulus. This is how we would put the electrodes on the scalp. And then the signal will go through. And in the graph here is the average amplitude of the signal. So this is the forward signal, the top pass signal, and the inhibitory signal, the reverse signal, and the average of those signals. And it's the average of those signals in different regions where your measurements are taken. The little picture on the side, on the right-hand side, shows you which regions you can take the measurements from. So this type of technique has not really been used in presbyopia measurements before. And we've done 2 papers now in this, but there was one paper before ours. But what they did was they wanted to compare multifocal lenses to monovision. And they adapted the patients for 3 weeks. So they had 3 weeks with monovision and 3 weeks with multifocal. And these patients were only measured at 1.3 meters. So they were only measured at one distance, the intermediate distance. They weren't measured at near, and they weren't measured for far away. So they had a small group of patients, and they didn't really find that there was any predictors to which patients would be successful. But they did find differences in the signals. And this kind of led to our paper. So what we were doing, the 2 papers, the first paper was looking at monovision in naive new contact lens wearers. So these patients were not adapted to monovision. This is the first time they're trying monovision. And in the second paper, these are patients who are new to multifocal contact lenses. Again, they haven't tried multifocal contact lenses before. So these are patients who are sort of presbyopia, about 50 years old. So their ads will be around 1.5, something like that. And this is just to show you the type of study we did. It was a randomized sequence. So the patients, this is the monovision study first of all. So the patients were checked for far distance with conventional monovision, and then in a binocular situation with both eyes corrected for far. And then the same for near. one eye with monovision, and then both eyes corrected for near. So they were binocular for near, or they were binocular for distance, or they had monovision and we looked at near, or we looked at far. So there were 4 conditions. For the multifocal lenses, it was a little bit more than that because we used 2 ads, a low ad and a medium ad. Now, in this case, the patients were binocular in all situations because they had the multifocal lens in both eyes. So either they had multifocal lenses in both eyes and we looked at their far distance or their near distance. But when we did the single vision, we used the near correction or the distance correction. The stimuli was Sloan letters. The picture you saw before, this was a 32-channel signal with 64 channels altogether. And these are the areas that we looked at. We looked at the parietal area, and this is the anterior insular area of the brain. And we also looked at the occipital area, which is the visual cortex. And first of all, just to show you the visual results, you can see that in a monofocal lens, so when the patients are wearing single vision lenses and they're looking far away, their best vision is with the single vision lenses, and the vision decreases with the low ad and the high ad, which is what you'd expect. Now, when we look at the near distance, again, the best vision is when they're binocular with single vision lenses for near. But the second best scenario is when they had the medium ad. So the low ad wasn't as effective as the medium ad. The medium ad was more effective for these patients. And that makes sense as well because the medium ad was around 1.5, 1.75, which actually is the correct ad for this age group of patients. This is just to show you the Radner chart, the reading speed and the critical print size. Again, you see the same effect. When they're wearing their distance contact lenses, their reading is very poor. When they're wearing single vision contact lenses for near, their reading vision is good. And then the second best scenario is when they're wearing the medium ad in multifocal lenses. So this is the complicated bit now. This is to look at the VEPs. First of all, I'm going to show you the multifocal results. Now, what happens when the signal goes in, there's an inhibition of the signal at around 60 milliseconds, but only in the occipital lobe, not in the parietal lobe. So you can see this picture here. The signal for the multifocal lens and the signal for the single vision lens are almost the same. When you look at this picture here, you can see the monofocal lens, the blue color, gives the best stimulus. And the multifocal lenses have a reduction in the amplitude of the signal. But then there's a compensatory measurement here. You can see this part here where we get this, what we call a compensatory activity. So the brain realizes that the signal is not as good, and so it increases the second signal, but only in the visual cortex. Now, when we looked at the monovision lenses, remember monovision, distance in one eye, near in the other eye? There was also an inhibition of the signal, a depression of the signal in the parietal lobe. So we think this is because these patients have lost their stereopsis. They also get the excitation in the reverse signal. So in the reverse signal, we have the same compensatory reading from the occipital lobe. What we don't see, what we can't see, is we don't see any evidence of which patients will be suited for which type of lens. So we can't predict which patients will have better success with multifocals or which will have better success with monovision. What we can see is that the brain reacts differently in the two situations. And also remember, these are naive patients, these are new patients. They never had monovision, they never had multifocals. Once they have adapted, the signals will be different. So these are the conclusions. You can see that the monovision has a depression in the parietal or the anterior insula. The multifocal doesn't. And I think the next step would be to look at this type of measurement in adapted patients as well as the non-adapted patients that we already tried it. So I want to acknowledge my co-workers, Dr. Fabrizio Zeri, who was the main person behind the study, and the colleagues in Milan and Rome. The measurements of this study were actually taken in Rome at the Trieste University in Rome, where they have a very good psychophysics department. So thank you very much. I know it's a complicated topic, but if you want to talk to me about it later on, I'm happy to talk to you about this. Thank you.